Hey everyone, as pharmacists, we're on the front lines dealing with the aftermath of acute coronary syndromes every single day. So, this explainer is designed to be a super practical guide. We're going to cut through the complexity and really zero in on the key drug therapy decisions made in the hospital, and maybe more importantly, the essential counseling points you'll be using right there at the pharmacy counter. Let's jump in.
So, here's our game plan. First, we'll do a quick flyby of what ACS actually is and how it's diagnosed. Then, we're going to get into the good stuff, the meds for both NSTSES and STEMI, and we'll wrap it all up with the most critical counseling pearls you can take back to your practice. All right, part 1. What exactly are we talking about with ACS? Getting this foundation right is key, because that initial diagnosis pretty much dictates the entire treatment path.
So, acute coronary syndrome, or ACS, is really just the big umbrella term for acute myocardial ischemia. You know, what most people call a heart attack. And what's happening? Well, almost always, it's a pesky atherosclerotic plaque that ruptures inside a coronary artery. That rupture kicks off a clot, a thrombus, and suddenly you've got a blockage cutting off blood flow.
Now, the first, and I mean the most critical fork in the road is based on the ECG. On one side, you have NSTEMIs. Think of this as a partial blockage. It covers both unstable angina and NSTEMI. But on the other side, you have STEMI. This means a complete coronary blockage. And that distinction, it's everything. It instantly separates a time-as-muscle, all-hands-on-deck emergency from a condition that we can initially manage with medications. So how do clinicians actually confirm the diagnosis and figure out just how aggressive they need to be? Well, that brings us to diagnosis and, you guessed it, risk stratification. The diagnosis really boils down to a clinical triad. You've got the patient's story, the ECG changes that tell us if it's a STEMI or NSTEMIs, and of course, cardiac biomarkers. Out of all of these, an elevated troponin level is the smoking gun. It's the definitive proof that heart muscle injury has actually happened.
And here is a fantastic clinical pearl for us, especially when doing a med rec. High-dose biotin supplements, the ones for hair, skin, and nails, can seriously interfere with the troponin test. It can cause falsely low results, which could dangerously delay a critical diagnosis. This is such a vital question to ask in a patient's history.
So, for those NSTEMI patients, risk is quickly sorted out in the ER using something called the TIMI score. It's a simple 7-point scale, and it helps guide just how intense the treatment should be, because a higher score directly means a higher risk of something bad happening.
And believe me, that risk goes up fast. A high TIMI score, say a 6 or 7, translates to a staggering 40.9% risk of death, another heart attack, or needing an urgent procedure within just 2 weeks. A number like that totally justifies the aggressive medical management these folks get right off the bat.
Okay, now we're getting to the heart of our practice. Let's really focus in on the key medications used for NSTASIC and the absolutely essential counseling you're going to provide. For every single patient you dispense sublingual nitro to, this 3-step process is non-negotiable. It has to be crystal clear. Step 1. At the very start of chest pain, take 1 dose. Step 2. If the pain is not better in 5 minutes, the most important thing is to call 911. Call 911 before you even think about taking a second dose. Then, while they're waiting for help to arrive, they can take up to 2 more doses, 5 minutes apart. Simple, clear, and absolutely life-saving. This one is a huge red flag, one of the most dangerous drug interactions we see. You always have to screen for PDE5 inhibitor use before dispensing a nitrate. Sildenafil or vardenafil in the last 24 hours or tadalafil in the last 48 hours is an absolute, no questions asked contraindication. Why? Because you're risking a catastrophic drop in blood pressure.
All right, let's talk about the cornerstone of treatment, dual antiplatelet therapy, or DAPT. This is all about preventing that clot from getting bigger or coming back. It means we combine good old aspirin with a second agent, a P2Y12 inhibitor, to basically block platelet activation from 2 different angles.
And we've got options for that second agent, each with its own little counseling quirk. With clopidogrel, remember it's a prodrug, so it needs CYP2C19 to work. With ticagrelor, the big one is to warn patients about a common, and usually harmless, feeling of shortness of breath. And for prasugrel, our most potent option, you've got to counsel on higher bleeding risk and double-check that the patient has absolutely no history of a stroke or TIA, because it's contraindicated.
Now, inpatient anticoagulation is standard practice. While enoxaparin is often the go-to, the key thing for us pharmacists to check is kidney function. If you see a patient with a creatinine clearance of 30 or less, you should expect to see a switch over to unfractionated heparin to avoid the drug building up.
Okay, let's totally switch gears now and talk about STEMI. This is an all-hands-on-deck emergency, and while some of the medications are the same, the whole approach and philosophy are critically different. With a STEMI, there is one goal and one goal only: reperfusion. We have to get that blocked artery open immediately to save the heart muscle. You've heard the saying, time is muscle, and it is literally true here. Every single minute counts. And there are basically two ways to do this. The gold standard is primary PCI, where a cardiologist goes in, mechanically opens up the artery with a balloon, and usually places a stent. Now, if a patient can't get to a hospital that can do PCI within about 2 hours, the alternative is fibrinolytic therapy, using a clot-buster drug like tenecteplase to dissolve the clot with medicine.
This is another huge therapeutic difference from NSD-ACS. While you might see calcium channel blockers used for symptoms there, in STEMI, they're absolutely contraindicated. The evidence shows they can actually increase morbidity and mortality. After a STEMI, it's beta blockers that are the standard of care for controlling heart rate and demand.
All right, let's bring it all home. We have covered a ton of ground, so let's boil it all down to the most important, high-impact messages that you need to deliver to every single patient who has survived an ACS event.
These are what I call the core four for long-term prevention: lifelong baby aspirin, a high-intensity statin, a beta blocker, and an ACE inhibitor. These are foundational. Our job is to really hammer home that these aren't just temporary fixes. They are absolutely essential for preventing this from ever happening again.
When you're counseling on DAPT, this slide really nails it. The two most important things we need to talk about are bleeding risk and adherence. We have to be really clear about the signs of bleeding, but at the same time, we have to stress that stopping these meds early can lead to a stent thrombosis, which can be fatal. It's a tricky balance. So this is how you have that bleeding risk conversation. You empower them. Tell them exactly what to look for: bruising more easily, black or tarry stools, a cut that just won't stop bleeding. The key instruction is to report these things right away. But, and this is the critical part, they must not stop taking the medication on their own. Call the doctor, call the pharmacist, but don't stop the pills.
So I'll leave you with a final thought to take into your practice. We know adherence to DAPT is life-saving, but that idea can be pretty abstract for our patients. So, what analogy will you use to make it stick? Is it like scaffolding holding up a new bridge in their artery? Or maybe it's like a 24/7 security guard for their heart. Finding that simple, powerful image, that's how we turn information into true understanding. Thanks for watching.